When neonates experience ventilator dyssynchrony, their cardiorespiratory system becomes unstable. Dyssynchrony increases mean airway pressure and causes abrupt swings in intrathoracic pressure. These pressure shifts alter venous return, pulmonary blood flow, and systemic perfusion. The cerebral circulation is especially sensitive, so each fluctuation in intrathoracic pressure translates into variability in cerebral and systemic blood flow. These rapid and repetitive changes have significant neurologic implications. Early preterm infants are particularly vulnerable because their cerebral vasculature has limited ability to autoregulate blood flow. Sudden increases or decreases in pressure created by fighting the ventilator, breath stacking, or ineffective triggering can elevate the risk of intraventricular hemorrhage. Likewise, abrupt surges in blood pressure associated with agitation or struggling can contribute to periventricular leukomalacia by injuring the immature white matter. There is also a strong interaction between discomfort, stress, and respiratory control. When an infant becomes distressed, catecholamine release increases, raising systemic oxygen consumption and amplifying the work of breathing. This stress response worsens agitation and can further disrupt synchrony with the ventilator. The result is a cycle in which pain or discomfort triggers dyssynchrony. Dyssynchrony increases physiologic stress, and the infant becomes progressively more unstable. These consequences underscore the importance of recognizing and correcting dyssynchrony promptly. Stabilizing pressure patterns, reducing agitation, and ensuring comfortable, well-coordinated support directly protect both cardiopulmonary and neurologic systems in fragile neonates. Inefficient or poorly coordinated ventilation produces immediate physiologic consequences for the neonate. When breaths are not synchronized with the infant's effort, tidal volumes become inconsistent and alveolar ventilation drops. This quickly leads to hypoxemia and hypercapnia because the infant cannot reliably exchange gas with each cycle. Asynchrony also increases the likelihood of repeated desaturation and bradycardia events, since even brief periods of inadequate ventilation can destabilize oxygenation and heart rate in fragile infants. The long-term effects are equally important. Recurrent asynchrony prolongs the duration of mechanical ventilation by preventing effective lung recruitment and increasing the work required to maintain adequate ventilation. Infants exposed to ongoing ventilatory instability show higher rates of bronchopulmonary dysplasia because the lungs experience repetitive stress, pressure variability, and inconsistent distending forces. These infants also require more sedation or neuromuscular blockade to maintain comfort and synchrony, further lengthening mechanical ventilation and introducing additional risks. The neurologic consequences emerge from the cumulative stress associated with repeated instability. Each episode of dyssynchrony generates swings in oxygenation, carbon dioxide levels, and blood pressure. Over time, these fluctuations contribute to neurodevelopmental impairment, particularly in preterm infants with vulnerable white matter and immature autoregulation. The impact is not from a single event, but from the cumulative burden of many small, unrecognized disturbances. The key message is that every dyssynchrony episode, even brief or subtle ones, adds physiologic stress that may influence outcomes. Recognizing and correcting these events is therefore essential to protecting pulmonary and neurologic health in neonates receiving ventilatory support. Dyssynchrony reflects a mismatch between the infant's respiratory effort and the ventilator's timing or flow delivery. Each type represents a different point in the breath cycle where this mismatch occurs. Trigger dyssynchrony occurs when the ventilator fails to recognize the infant's attempt to initiate a breath. The infant generates an inspiratory effort, but the ventilator does not trigger, creating a missed breath. This often happens when trigger sensitivity is set too low, when intrinsic positive end expiratory pressure must be overcome before the ventilator senses flow, or when a leak prevents the ventilator from detecting the infant's effort. The infant continues trying to inhale against a closed system, increasing work of breathing. Flow dyssynchrony develops when the flow delivered by the ventilator does not match the infant's inspiratory demand. If the ventilator provides less flow than the child is trying to pull in, the infant must generate additional effort, and the waveform begins to show a concave or scooped appearance. Flow dyssynchrony can also create irregularities on the flow time curve as the ventilator and infant alternately compete for control of inhalation. Cycle dyssynchrony occurs when the ventilator terminates inspiration at a time that does not match the infant's neural timing. If inspiration ends too early, premature cycling, the infant receives an incomplete tidal volume and may immediately attempt to re-inhale. If inspiration ends too late, delayed cycling, the infant is forced to exhale against ongoing inspiratory flow. This can produce breath stacking or double triggering, where two ventilator breaths occur for a single infant effort. Expiratory dyssynchrony describes a mismatch during exhalation. If the infant begins to exhale while the ventilator is still delivering inspiratory flow, the two forces oppose each other. The pressure waveform may show sharp spikes, and the flow curve becomes distorted because the infant's active exhalation is pushing against incoming gas. This increases work of breathing and contributes to physiologic instability. Together, these patterns illustrate how dyssynchrony can occur at any phase of the ventilatory cycle and highlight the importance of monitoring waveforms closely to identify the underlying cause. Waveforms provide the earliest and most reliable clues that the infant and ventilator are not working together. Each scalar reveals different mechanical signatures of dyssynchrony. On the pressure time waveform, a negative dip just before the ventilator delivers a breath indicates that the infant is attempting to initiate inspiration, but the ventilator has not recognized the effort. This represents a missed trigger. Double triggering appears as two pressure peaks occurring back to back. The infant's inspiratory effort continues beyond the ventilator's set inspiratory time, causing a second unintended breath. A concave rise in the pressure waveform during inspiration reflects flow starvation. The ventilator is not delivering flow quickly enough to match the infant's demand, so the infant must pull additional negative pressure to achieve the desired volume. On the flow time waveform, irregular inspiratory spikes represent abrupt changes in flow caused by patient effort competing with ventilator-delivered flow. These spikes disrupt the smooth inspiratory contour and signal that the infant is intermittently taking control of the breath. Early inspiratory cutoff, where flow suddenly drops before the infant has completed inhalation, suggests premature cycling. A delayed return to baseline reflects insufficient expiratory time or dynamic hyperinflation. On the volume time waveform, unequal or irregular tidal volumes between breaths point to inconsistent interaction between patient effort and ventilator timing. If the ventilator terminates inspiration early or misses a trigger, the delivered volume may be much smaller than expected. Conversely, if two breaths stack or the infant assists the ventilator, the tidal volume may rise unexpectedly. These variations signal instability in the breathing pattern. Together, these waveform clues provide a real-time window into the infant's interaction with the ventilator, allowing rapid detection and correction of dyssynchrony before it leads to instability. Managing dyssynchrony requires intervening at the specific point where the infant and ventilator are no longer aligned. The first step is optimizing trigger sensitivity. Using flow triggering or proximal sensors allows the ventilator to detect even very small inspiratory efforts, which is essential in neonates with weak or inconsistent signals. Sensitivity must be balanced carefully. Settings that are too low cause missed triggers, while overly sensitive settings may introduce auto-triggering from leaks, water movement, or minor circuit vibrations. Next, flow must match the infant's inspiratory demand. If flow delivery is slower than the infant's natural effort, the pressure waveform develops a concave scooped appearance as the infant pulls harder to achieve the desired volume. Adjusting the rise time or modifying the flow pattern restores synchrony by ensuring the ventilator provides adequate flow at the beginning of inspiration. Cycling and expiratory timing also play a central role. Inspiratory time should align with the infant's neural inspiratory duration so that the ventilator ends the breath when the infant intends to exhale. If inspiration ends too early, the infant receives an incomplete tidal volume. If it ends too late, the infant is forced to exhale against ongoing flow. Adjusting the inspiratory time restores this alignment. Adequate expiratory time is equally important. If expiration is too short, air trapping and intrinsic positive end expiratory pressure develop, making it harder for the ventilator to detect triggers and increasing work of breathing. Finally, improving comfort and stability directly reduces dyssynchrony. Maintaining temperature, minimizing unnecessary handling, and reducing environmental stress all prevent agitation-related surges in respiratory effort. Gentle containment and swaddling support the infant's natural posture and decrease extraneous movement during ventilation. When the infant is calm and stable, synchrony improves and ventilatory support becomes more effective and safer. Several ventilator modes incorporate features designed to improve synchrony by aligning machine support with the infant's own breathing pattern. Conventional modes such as synchronized intermittent mandatory ventilation use a trigger signal to detect the infant's effort and deliver mandatory breaths in phase with spontaneous activity. This reduces the mismatch that occurs when mandatory breaths arrive at the wrong point in the infant's cycle. Pressure support ventilation further improves synchrony by allowing the infant to determine both the onset and the duration of inspiration, while the ventilator augments each breath with additional flow and pressure. Volume guarantee or volume-targeted pressure control adds another layer of stability by adjusting inspiratory pressure to ensure consistent tidal volumes despite changes in compliance or resistance. More advanced synchrony support is available with neurally adjusted ventilatory assist. This mode detects the electrical activity of the diaphragm through an esophageal catheter. Because the system responds directly to the infant's neural respiratory drive, breath initiation, flow delivery, and cycling occur at the precise moment the infant intends to breathe. This eliminates many of the timing errors inherent in pressure or flow-triggered modes. Improved alignment between neural effort and ventilator response has been associated with fewer desaturation events, reduced apnea, and decreased need for sedation, particularly in preterm infants who are vulnerable to dysregulated breathing patterns. These modes do not change the underlying physiology, but they greatly improve the ventilator's ability to work with, rather than against, the infant's own respiratory control. Abnormal ventilator waveforms can nearly always be traced back to one of a few major mechanistic categories. Grouping patterns this way helps simplify interpretation and directs attention to the most likely clinical cause. The first category is airway resistance changes. Any increase in resistance, whether from obstructive lung disease, thick secretions, or the small internal diameter of a neonatal endotracheal tube, changes the slope and contour of both pressure time and flow volume waveforms. These infants often show scooped expiratory limbs, reduced peak flows, and irregularities caused by intermittent partial obstruction. The second category involves compliance changes. Conditions such as respiratory distress syndrome, pulmonary edema, pneumothorax, or overdistension alter how easily the lung expands for a given pressure. Reduced compliance leads to flattened loops, reduced tidal volume, and steeper pressure rises. Overdistension creates beaking or top flattening on the pressure-volume loop. These patterns highlight whether the lung is stiff, collapsed, or being pushed too far. The third category includes leaks and air trapping. An incomplete seal around the endotracheal tube or an uncuffed tube allows volume to escape during exhalation, producing open or incomplete loops. Short expiratory times, especially in small infants with long-time constants, prevent the lung from returning to baseline and result in air trapping or intrinsic positive end expiratory pressure. These patterns shift loops rightward, widen end expiratory volumes, and disrupt closure. The final category is patient effort and asynchrony. Timing mismatches between the infant and ventilator distort nearly every waveform. Trigger errors create negative pressure dips, flow mismatches produce concave inspiratory rises, and cycle mismatches create double triggering or premature cutoffs. These abnormalities reflect the infant's attempt to breathe out of phase with machine support. By recognizing which mechanistic group a waveform abnormality belongs to, clinicians can rapidly narrow the differential and target the appropriate corrective action. Pressure abnormalities can be interpreted by examining how peak inspiratory pressure and plateau pressure change in relation to each other. These two measurements allow us to distinguish resistance problems from compliance problems and from patient-related factors such as active effort or air trapping. When peak inspiratory pressure rises while plateau pressure remains normal, the problem lies in airway resistance. The ventilator must generate higher pressure to deliver flow through a narrowed or obstructed airway, but once flow stops during the inspiratory pause, the plateau pressure settles at a normal value because lung compliance is unchanged. Conditions such as meconium aspiration, mucus plugging, bronchospasm, or a kinked endotracheal tube all increase resistance. Correction focuses on clearing the airway, suctioning, bronchodilator therapy, or confirming the tube is unobstructed. When both peak inspiratory pressure and plateau pressure rise, compliance is reduced. Here, the lung itself is stiff, and greater pressure is required both to generate flow and to hold the delivered volume at end inspiration. Elastic recoil has increased, so the pressure during the inspiratory pause remains elevated. This pattern is seen in respiratory distress syndrome, pulmonary edema, and pneumothorax. Management centers on improving recruitment with positive end expiratory pressure, verifying adequate tidal volume, and assessing for leak. High peak inspiratory pressure with an oscillating baseline reflects active patient effort. The infant is either fighting the ventilator or breathing asynchronously, generating pressure swings on top of the ventilator-delivered pressure. Crying, discomfort, or agitation causes rapid fluctuations in the pressure tracing. Optimizing trigger sensitivity, improving comfort, and addressing pain or agitation helps stabilize this pattern. An upward drift in the baseline pressure suggests autopositive end expiratory pressure or a leak. In air trapping, incomplete exhalation causes residual positive pressure to carry over into the next breath, elevating the baseline. Leaks may mimic this by altering the measured pressure. This is common in bronchopulmonary dysplasia, where airway collapse and uneven time constants limit full exhalation. Correction includes lengthening expiratory time and inspecting the system for leaks. By pairing waveform appearance with the relationship between peak and plateau pressures, the underlying mechanical problem becomes much easier to identify and correct. Flow abnormalities provide some of the clearest clues about how the infant and ventilator are interacting. Each pattern reflects a distinct disruption in how gas moves through the airway or circuit. When expiratory flow fails to return to zero, the infant is not fully emptying before the next breath begins. This occurs with autopositive end expiratory pressure or incomplete exhalation. A short expiratory time or obstruction prevents the lung from reaching its resting volume, so flow remains above baseline. This pattern is common in bronchopulmonary dysplasia or when the ventilator rate is set too high. Correction involves reducing the ventilator rate or lengthening the inspiratory to expiratory ratio to provide additional time for passive recoil. A concave inspiratory limb represents flow starvation. Here, the ventilator is not supplying flow as quickly as the infant demands, so the infant generates negative pressure early in inspiration. This pulls the waveform downward into a scooped shape. It is commonly seen when the ventilator is set with a slow rise time or a low flow profile in pressure control or pressure support modes. Increasing the flow or adjusting rise time corrects the mismatch. Irregular oscillations on the flow curve are usually caused by patient movement, effort, or circuit artifact. Crying, struggling, or intermittent active breathing introduces abrupt changes in flow. Condensation or water sloshing in the tubing can also create short-lived flow spikes that distort the scalar. Correction focuses on improving comfort and draining condensation from the circuit. A flattened inspiratory flow indicates either a leak or a sensor error. When a significant leak is present, around an uncuffed tube or at a poor circuit connection, the ventilator cannot generate or measure normal inspiratory flow, so the curve becomes blunted. Sensor issues, such as a misaligned or contaminated proximal sensor, produce the same appearance by undermeasuring the true flow. Correction involves identifying and repairing the leak, and recalibrating or replacing the flow sensor if needed. Together, these flow patterns illustrate how airway mechanics, ventilator settings, and circuit integrity shape each breath. Recognizing them quickly allows targeted corrections that restore efficient ventilation. Volume scalars help identify problems with exhalation, delivered tidal volume, and the interaction between the infant and the ventilator. When the expiratory limb fails to return to baseline, the infant is not fully emptying before the next breath. In neonates with BPD or meconium aspiration, long time constants and small airway collapse delay exhalation, so the next inflation occurs on top of trapped gas. This pattern signals intrinsic PEEP and rising end expiratory pressure. Extending the expiratory phase gives the lung adequate time to clear the previous breath. When inspiratory volume exceeds expiratory volume, the loop reflects lost volume rather than retained volume. Neonates ventilated with uncuffed tubes or loose circuit fittings frequently lose a portion of the delivered breath to ambient air. This appears as a gap between the inspiratory and expiratory limbs. Correcting the leak restores symmetry and ensures the displayed tidal volume represents what the infant actually receives. Sawtooth oscillations represent either patient activity or artifact. Infants who are moving, actively breathing over the ventilator, or have condensation oscillating within the tubing generate irregular small fluctuations along the scalar. These changes distort the true shape of the volume curve. Removing circuit water and improving comfort helps determine whether the pattern is physiologic or environmental. An abrupt drop in volume mid-inspiration occurs when the infant actively exhales against the ventilator or when the breath cycles prematurely. The infant's effort briefly reverses flow, breaking the normal upward trajectory of the volume limb. This finding reflects asynchrony, often driven by discomfort, inappropriate inspiratory time, or unexpected exhalation reflexes. Adjusting cycling criteria reduces mid-breath flow reversal and stabilizes delivered volume. Recognizing these abnormalities provides a direct assessment of exhalation adequacy, leak severity, and synchrony. Matching expiratory time to lung mechanics, correcting leaks, removing artifacts, and aligning the breath cycle with the infant's effort prevents air trapping, ensures accurate tidal volume monitoring, and improves overall ventilation stability. Volume waveforms reveal how effectively each breath delivers and returns tidal volume. And abnormalities often point directly to problems with timing, resistance, or leaks. When the expiratory limb does not return to baseline, the lung is not fully emptying before the next breath starts. This represents air trapping or intrinsic positive end expiratory pressure. Incomplete exhalation, whether due to a short expiratory time, high resistance, or obstruction, leaves residual volume in the lung. This pattern appears in bronchopulmonary dysplasia, meconium aspiration syndrome, or when the ventilator rate is too high for the infant's mechanical time constants. Correcting this involves extending expiratory time so the lung can fully recoil. When inspiratory volume exceeds expiratory volume, a leak is present. The ventilator successfully delivers volume, but part of that volume escapes through the airway instead of returning through the flow sensor. This is common with uncuffed endotracheal tubes, poor tube positioning, or loose circuit connections. The result is a visible gap between the inspiratory and expiratory limbs. Correction focuses on repositioning or securing the tube and tightening circuit fittings. Sawtooth oscillations appear when there is intermittent disruption to flow, usually from patient effort or mechanical artifact. Active breathing during inspiration or expiration produces small volume shifts that create a jagged waveform. Condensation in the ventilator tubing can mimic the same irregularity as water moves back and forth. These oscillations reflect noise in the system rather than true tidal volume variation. Draining the circuit and improving infant comfort stabilize the waveform. An abrupt volume drop mid-inspiration indicates premature cycling or active exhalation during the inspiratory phase. If the ventilator ends inspiration too early, or if the infant forcefully exhales against incoming flow, the inspiratory volume falls suddenly. This is a hallmark of asynchrony. Adjusting the cycling criteria so inspiration ends when the infant naturally transitions to exhalation restores a smooth, complete inspiratory waveform. These volume patterns provide critical insight into leak magnitude, timing mismatch, and adequacy of exhalation, allowing tailored adjustments that improve synchrony and support effective ventilation. In neonatal ventilation, most waveform abnormalities fall into a few recurrent categories. Resistance-related changes are extremely common because neonates have very small endotracheal tubes and highly reactive airways. Mucus plugs, tube narrowing, and dynamic airway collapse all increase resistance and immediately distort both flow and pressure waveforms. Compliance-related changes appear frequently as well, especially in infants with evolving respiratory distress syndrome, fluid overload, or pneumothorax. These conditions stiffen the lung, reducing the volume delivered for a given pressure and altering the shape of the pressure-volume loop. Leak-related issues are another major source of waveform distortion in neonates. Uncuffed tubes, sensor drift, and loose circuit connections cause inspiratory and expiratory limbs to separate, reduce measured tidal volume, and impair trigger detection. Finally, asynchrony remains a major contributor to instability. Trigger delay, double triggering, and flow starvation all arise when the ventilator's timing or flow delivery does not align with the infant's neural effort. If these abnormalities go uncorrected, the consequences are significant. The infant's work of breathing increases as they try to compensate for inefficient support. Ventilator instability leads to episodes of hypoxemia and carbon dioxide retention. Repeated pressure swings create wide fluctuations in cerebral blood flow, an especially dangerous problem in preterm infants at risk of intraventricular hemorrhage. Over time, these disturbances prolong ventilator dependence and contribute to the development of bronchopulmonary dysplasia. The key point is that early recognition and correction of waveform abnormalities is not simply about improving ventilator graphics. It directly prevents physiologic instability and reduces the risk of long-term lung and neurologic injury. Mastery of waveform interpretation allows clinicians to intervene before instability accumulates into harm. Real-world waveforms rarely look as clean or perfectly shaped as the textbook examples. Clinical signals pass through sensors, tubing, and hardware before they reach the screen, and each of these elements introduces small distortions. Patient movement, breathing variability, and minor circuit fluctuations also influence the appearance. Even during stable ventilation, breath-to-breath variation is normal, so the goal is not a perfectly uniform tracing, but a consistent pattern that reflects the infant's physiology. Several common sources of variation should be expected at the bedside. Sensor lag creates a delay between actual flow or pressure changes and what appears on the monitor. In rapidly breathing neonates, this lag can make waveforms appear slightly shifted or blunted. Condensation in the circuit produces oscillations or erratic spikes, especially on the flow waveform as water droplets move with each breath. This can mimic pathology unless recognized as an artifact. Gas compression and humidification also soften waveform edges. Because part of the delivered volume goes into compressing the circuit and warming humidified gas, pressure and flow tracings lose some of their sharpness compared with textbook loops. In tiny preterm infants, cardiac oscillations may be visible as small rhythmic ripples on the pressure curve. The proximity of the heart to the compliant chest wall allows each heartbeat to transmit pressure pulses into the airway, creating subtle, repeating deflections that are physiologic rather than pathologic. Finally, spontaneous breathing effort adds minor negative dips, slight scooping, or small flow irregularities, even when the infant is comfortable and synchronous. These do not necessarily indicate dyssynchrony. They simply reflect natural variability in neural respiratory drive. Interpreting waveforms in the NICU requires recognizing these real-world influences, so normal variation is not mistaken for dysfunction. Distinguishing artifact from true abnormality is essential for accurate clinical decision-making. Waveforms do not always reflect lung physiology. Many disturbances originate from the circuit, ventilator hardware, or infant movement. Recognizing these artifacts prevents misinterpretation and unnecessary ventilator adjustments. Circuit water is a frequent source of repetitive oscillations on the flow scalar. Even a small amount of condensation can move with each breath and create rhythmic perturbations that resemble patient effort. Sensor drift or partial circuit disconnection flattens or distorts the scalars because the ventilator loses accurate reference points for flow or pressure. Movement has a large impact in neonates. Sudden flexion, crying, or kicking shifts airway pressure and creates irregular baseline fluctuations that do not correlate with any physiologic pattern. Suctioning produces abrupt spikes or transient negative deflections as the airway is briefly exposed to ambient pressure. During ventilator recalibration, signals can pause or flatten because the machine temporarily suspends measurement. A reliable way to distinguish artifact from pathology is consistency. True abnormalities repeat breath after breath and appear across several scalars. Artifacts, by contrast, are transient and usually isolated to a single waveform. When an unexpected change appears, comparing pressure, flow, and volume together helps determine whether the disturbance represents lung mechanics or an external influence. Understanding these non-physiologic patterns prevents misclassification of noise as disease. Misinterpreting artifacts may lead to inappropriate changes in PEEP, cycling, trigger sensitivity, or support level. Correct identification ensures that ventilator adjustments are based on the infant's physiology rather than equipment-related distortion. Plateau pressure represents the alveolar pressure when airflow is momentarily stopped. This pause removes the resistive component of the breath and isolates the pressure generated purely by the elastic properties of the lung and chest wall. It is one of the most reliable ways to assess the true distending pressure the infant's alveoli experience. To obtain a meaningful value, the ventilator must perform a brief inspiratory hold during a passive breath. The hold is typically less than half a second to avoid discomfort, but long enough for flow to fall to zero. During this moment of no flow, the pressure displayed on the scalar reflects alveolar pressure rather than pressure lost across the airway. The maneuver is only accurate if the infant remains passive, because any inspiratory effort will create an artificial drop, and any expiratory effort will elevate the measured plateau. Several neonatal factors can limit accuracy. Leaks around uncuffed tubes or from circuit connections prevent equilibrium between the ventilator and alveoli, producing a falsely low reading. Infants with very short time constants may not achieve true zero flow before the hold ends. Spontaneous breathing can interrupt the maneuver entirely. Because of these challenges, a single isolated value is less useful than observing how plateau pressure trends over time in response to interventions or disease progression. Used appropriately, plateau pressure helps differentiate whether rising pressures come from worsening compliance or increasing airway resistance. In the NICU, trending PEEP ensures that adjustments to ventilator settings support gas exchange while maintaining safe distending pressures that protect fragile alveoli. Not every irregularity on a ventilator waveform reflects a change in the infant's physiology. Many come from environmental or equipment-related factors, and recognizing these artifacts prevents unnecessary interventions. Water in the circuit is one of the most frequent causes. As water oscillates within the tubing, it generates repetitive rhythmic distortions on the flow scalar. These oscillations have no relationship to the infant's breathing pattern, but they can mimic airway obstruction or erratic effort if not recognized. A circuit disconnection or drifting sensor produces flattened or erratic traces. When the flow or pressure sensor loses calibration or moves out of alignment, the waveform can appear artificially dampened or unstable, even when the infant is breathing normally. Infant movement or crying introduces irregular fluctuations along the baseline. These originate from muscular contractions and rapid changes in chest wall pressure rather than true airway mechanics. They often appear as jagged, inconsistent shifts across all scalars. Suctioning creates abrupt spikes or sudden negative flow reversals. As the suction catheter disrupts normal airflow, the ventilator briefly detects extreme variations in flow and pressure, which disappear once the procedure ends. Ventilator recalibration is another important non-physiologic cause. During automatic self-checks or sensor resets, the ventilator may momentarily flatten signals or pause waveform output entirely. These are transient and have no clinical significance. A key recognition tip is that artifacts are transient. They tend not to repeat in consecutive breaths and often appear on only one scalar. In contrast, true physiologic abnormalities persist over time and correlate across pressure, flow, and volume waveforms. Clinically, distinguishing artifact from pathology is essential. Misinterpreting an artifact as a disease process can lead to unnecessary changes in ventilator settings or inappropriate escalation of support. A careful pattern-based approach ensures that adjustments are based on true physiologic need. Ventilator graphics do more than reveal patterns. They also allow several important quantitative measures to be extracted directly from the waveforms. These measures help describe the infant's mechanical status and guide clinical decision-making. Driving pressure, calculated as peak inspiratory pressure minus positive end expiratory pressure, reflects the elastic load placed on the lung. It represents how much pressure is actually used to generate tidal volume. In neonates, maintaining a driving pressure in the range of 10 to 15 centimeters of water is generally considered safe and reflects adequate compliance without excessive distending force. Plateau pressure is obtained through an inspiratory hold maneuver when flow temporarily stops and alveolar pressure equilibrates. This value represents alveolar pressure at zero flow. Keeping plateau pressure below 25 centimeters of water helps minimize the risk of ventilator-induced lung injury. Mean airway pressure is derived from the area under the pressure time curve. It reflects the average distending pressure applied throughout the entire respiratory cycle and is a major determinant of oxygenation. Because it depends on mode, rate, and inspiratory time, typical values vary with disease state and ventilator strategy. The time constant, calculated from the slope of the flow or volume decay curve during exhalation, represents the product of resistance and compliance. In neonates, a time constant between 5/100ths and 15/100ths of a second is typical. It defines how long the lung needs to empty. Shorter expiratory times risk air trapping in infants with longer time constants. Finally, the stress index is derived from the slope of the pressure time curve during inspiration. A value greater than 1 suggests overdistension. The pressure curve bows upward as the lung stiffens at high volumes. A value less than 1 suggests recruitment. The curve bows downward as additional alveoli open. A stress index near 1 indicates that tidal ventilation is occurring on the most stable portion of the compliance curve. Together, these measures translate visual waveform interpretation into objective markers of lung mechanics and ventilator safety in neonatal care. Interpreting graphics in real clinical settings requires attention to context rather than isolated waveform features. A waveform must always be evaluated alongside the infant's fractional inspired oxygen requirement, overall stability, disease trajectory, and the degree of sedation or spontaneous activity. These factors influence both the shape of the breath and the variability between breaths. Before drawing conclusions, confirm that the observed pattern persists across several cycles and is not a transient artifact. Comparing graphics before and after an intervention provides a more reliable signal than interpreting a single breath in isolation. Clinical judgment anchors the interpretation process. A lone abnormal deflection may simply reflect motion, repositioning, or a brief spontaneous effort rather than true pathology. Alignment with the physical exam, vital sign trends, and blood gas data ensures that waveform-based assessments remain physiologically grounded. Graphics are designed to complement the bedside assessment by providing real-time insight into mechanics, synchrony, and airway behavior, but they cannot replace a thorough clinical evaluation. Waveform assessment is valuable, but it comes with inherent constraints that must be recognized to avoid overinterpretation. Technical factors can influence the appearance of scalars and loops. Flow and pressure sensors do not register data simultaneously, which can create subtle timing offsets. Proximal sensors may drift over time, leading to changes in displayed values independent of the infant's physiology. Circuit compliance, water accumulation, and even small leaks can distort measured pressure or flow. These issues vary among ventilator platforms, so identical physiology may appear different on the Servo, VN500, or Fabian. Clinical limitations also shape interpretation. Infants often breathe spontaneously or exhibit agitation, which introduces asymmetry and inconsistency between breaths. These variations can resemble disease patterns if viewed without context. High-frequency modes are particularly prone to artifact that may mimic obstruction or leak. Importantly, not every waveform change is pathologic. Graphics must be integrated with the infant's mechanics, stability, and ventilator mode to ensure accurate interpretation. The essential message is that graphics function best as a trend indicator, not an exact measurement device. Consistent patterns over time carry more diagnostic value than any single breath, and waveform findings should always be corroborated with the broader clinical picture. Graphic-guided titration allows the clinician to move beyond fixed settings and adjust ventilation based on how the infant's lungs are actually behaving breath to breath. Pressure, flow, and volume patterns reveal whether gas exchange is being supported with an efficient combination of tidal volume, mean airway pressure, and inspiratory timing. Using these signals, support can be fine-tuned to minimize the mechanical load on immature lungs while still achieving adequate ventilation and oxygenation. Waveforms also guide adjustments that improve synchrony. Identifying flow starvation, premature cycling, or missed triggers enables targeted changes that reduce the infant's work and stabilize blood gases. This approach reduces unnecessary exposure to high pressures or large volumes by ensuring each change has a physiologic purpose, rather than relying on trial and error. The central concept is that graphics provide immediate feedback. Within a few breaths, the impact of modifying rise time, PEEP, inspiratory time, or sensitivity becomes visible. This rapid response allows clinicians to titrate support in real time and evaluate the effectiveness of each adjustment with greater precision. Matching inspiratory flow to the infant's demand is central to preventing avoidable work of breathing and minimizing dyssynchrony. On the pressure time waveform, inadequate flow delivery appears as a concave rise during inspiration. This shape reflects the ventilator's inability to meet the infant's inspiratory effort, resulting in negative intrathoracic pressure swings and unstable ventilation. In contrast, an excessively rapid rise time produces a sharp overshoot or spike at the start of inspiration, indicating that flow is being delivered faster than the infant can comfortably accept. Optimization focuses on shaping a smooth and physiologic pressure rise. Increasing rise time gradually corrects the concavity and ensures the ventilator is matching the infant's instantaneous flow needs. In pressure-controlled ventilation, the goal is a decelerating flow pattern that remains adequate throughout inspiration without producing excessive initial flow. Adjustments should be made in small increments while observing several consecutive breaths to confirm a stable response. Proper tuning of flow and rise time improves synchrony, reduces respiratory workload, and prevents misinterpretation of pressure abnormalities caused by flow mismatch rather than true compliance or resistance changes. PEEP adjustments should be guided by graphics that illustrate where the lung transitions from collapse to safe recruitment. On the pressure-volume loop, the lower inflection point represents the pressure where alveoli begin to open consistently. Setting PEEP slightly above this point helps stabilize newly recruited units and reduces cyclic atelectasis. As the loop rises toward the upper inflection point, the slope begins to flatten, indicating diminishing compliance and the onset of overdistension. Avoiding pressures in this region protects vulnerable alveoli from stretch injury, particularly in evolving RDS. The flow time scalar offers complementary information about whether the selected PEEP and respiratory rate permit complete exhalation. When expiratory flow consistently returns to baseline, alveolar emptying is adequate. Failure to reach baseline suggests air is being trapped, either from excessive PEEP or an insufficient expiratory phase. This pattern can quickly escalate into intrinsic PEEP and rising work of breathing. Clinically, PEEP should be titrated in small steps while simultaneously observing loop behavior and oxygenation trends. Effective titration balances the need for recruitment against the risk of overinflation, which is especially important in conditions with rapidly changing compliance, such as post-surfactant RDS. Using both loop and flow scalars together provides a more accurate assessment of where the lung sits on its pressure-volume curve and supports safer, physiology-driven optimization. Tidal volume selection should be guided by the appearance of the pressure-volume loop, which reflects how efficiently the lung accepts volume at a given pressure. When the loop has a small area or a shallow slope, the lung is either poorly inflated or operating on the flat portion of its compliance curve. This indicates that delivered tidal volume is insufficient for the current mechanics. In contrast, the development of a sharp peak at the top of the loop signifies that the ventilator is pushing beyond the optimal inflation point, creating overdistension with each breath. To optimize support, tidal volume or peak inspiratory pressure is adjusted to achieve full, smooth inflation without creating that overdistension peak. Because neonatal compliance can change rapidly, driving pressure becomes an important trend marker. As compliance improves, the difference between peak inspiratory pressure and PEEP decreases, and failure to adjust settings may result in unnecessarily large tidal volumes despite stable displayed numbers. In neonates, typical tidal volume targets fall around 4 to 6 milliliters per kilogram, with slightly higher values needed in restrictive processes. These targets are dynamic rather than fixed. Surfactant administration, shifts in lung water, or changes in PEEP alter the compliance curve, and tidal volume must be reassessed after each of these interventions to avoid either underventilation or unrecognized stretch injury. Using graphics to detect these shifts allows the ventilator to be aligned with the infant's lung mechanics in real time. Poor synchrony reflects a mismatch between the infant's respiratory effort and the ventilator's timing or flow delivery. The pressure time scalar often provides the earliest clue. Negative deflections before inspiration indicate the infant is attempting to trigger, but the ventilator is not responding. Double triggering or stacked breaths occur when the ventilator cycles too early and the infant continues to inhale, while irregular flow patterns suggest inconsistent support. On the volume scalar, variability in delivered tidal volume from breath to breath reflects unstable interaction between patient effort and ventilator assistance. Management focuses on restoring alignment between the ventilator's breath delivery and the infant's native rhythm. Trigger sensitivity is adjusted so that small inspiratory efforts are appropriately recognized without promoting auto-triggering. Inspiratory time is modified to approximate the infant's spontaneous inspiratory duration. Excessive cycling mismatch increases work of breathing and may introduce pressure swings that destabilize cerebral and systemic flow. When discomfort or agitation is contributing to waveform irregularity, supportive measures such as containment, positioning, or judicious sedation may reduce extraneous effort that the ventilator cannot accommodate. When synchrony is improved, the graphics become smooth and reproducible, reflecting stable interaction between effort and support. Clinically, this translates to reduced work of breathing, fewer physiologic swings, and more efficient ventilation with lower pressure exposure. In neonates, especially preterm infants, this stability is essential to minimize variability in intrathoracic pressure and the downstream risks associated with cardiopulmonary stress. Weaning decisions in neonates are most reliable when based on trend analysis rather than isolated breaths. Stable, symmetric scalars across pressure, flow, and volume suggest that the infant and ventilator are consistently well-matched with minimal asynchrony. When inspiratory flow delivery meets demand and expiratory flow returns smoothly to baseline, work of breathing remains low and there is no evidence of air trapping or developing auto-PEEP. A gradual decline in required PIP and driving pressure over time indicates improving compliance or reduced resistance load. This pattern is especially important in evolving RDS or recovering obstructive processes, where single breath variability can obscure the underlying trajectory. Consistent expiratory return to zero flow without a tail or upward drift confirms adequate exhalation at the current rate and inspiratory time, which is essential before reducing support. Weaning is performed incrementally, guided by sustained waveform stability. Each reduction in PIP VT target or support pressure should be evaluated over multiple minutes to ensure preserved symmetry and no emergence of scooping, missed triggers, or rising baseline flow. Using trends prevents premature changes driven by transient motion, artifact, or spontaneous breaths that do not reflect true readiness. When trended correctly, the graphics provide continuous feedback on the infant's physiologic tolerance to weaning and help prevent setbacks from undersupport or early fatigue. Ventilator graphics provide a continuous window into pressure, flow, and volume relationships, allowing real-time assessment of how the infant's lungs interact with the ventilator. They reveal compliance, resistance, synchrony, and the effectiveness of support long before changes are apparent in vital signs or blood gases. Mastery of these patterns turns routine ventilation into targeted, protective care. Scalars and loops help identify the underlying physiology. Whether a rising inspiratory pressure slope reflects decreased compliance, whether scooped expiratory flow indicates obstruction, or whether a widening loop suggests asynchrony. Recognizing these deviations allows immediate correction of the mechanical cause rather than treating downstream instability. Clinically, waveforms must be interpreted as trends, not isolated breaths. A single abnormal cycle often reflects motion, artifact, or spontaneous effort, while persistent patterns signal true pathology. Integration with the infant's respiratory drive, disease phase, and stability ensures that waveform-guided adjustments remain physiologic rather than numeric. Each waveform acts as feedback. Flow patterns refine rise time, pressure. Volume loops guide PEEP selection, and driving pressure trends help minimize injury while maintaining gas exchange. When interpreted consistently, graphics support safer ventilation by preventing over-distension, reducing resistance burden, and improving synchrony. The overarching message is that structured waveform interpretation transforms ventilation from reactive adjustments to deliberate physiologic management.